I'll be discussing about dental implant guidelines. And along with me, joined by Dr. Karnik Shah. In today's presentation, I'll be discussing about space parameter for dental placement, radiographs and CBCT imaging, implant guides or stents, osteotomy preparation, and then last will be restorative options. These are the steps that I will be discussing about. So let's start one by one. My first guideline will be space parameter for the implant placement. So as we know, when we are planning for the implant, the distance between the natural tooth and implant should be at least minimum 1.5 to 2 millimeter, and the distance between the two implant should be minimum 3 millimeter. So distance from the opposing tooth, the distance from the platform of the implant to an opposing tooth should be minimum 7 millimeter. If cement written crown is to be used, the minimum collar of an abutment is 1 millimeter. You need 4 millimeter of clinical crown height of the abutment for proper retention, and 1 millimeter for metal of the crown and 1 millimeter for porcelain. If you don't have 7 millimeter distance from the opposing tooth, then don't go with the cement written crown. Go with the screw written crown in that particular scenario. So space parameter for implant, again we are discussing. So implant shoulder to the CEJ of the adjacent tooth is usually 2 millimeter apical to the adjacent tooth's CEJ. So let's discuss it's a 3 into 3 into 3 pi rule. So these are four rules that we're going to discuss. The first rule is implant platform should be 3 millimeter apical to the zenith of the gingival margin. The second rule is center of the implant should be at least 3 millimeter palatal to the facial margins. And rule number 3 is 3 millimeter spacing should be present between the adjacent implant platforms. And rule number 4 will be implant should emerge through the palatal incisal edge of the crown positions. So now second aspect of the guideline will be radiographs and CBCT. Why? What's the importance of the radiographs and CBCT imaging? So it helps identify and diagnose any disease activity. It also determines the bone quality and quantity. Also, it determines the potential implant position and orientation. So let's discuss about the distortion factors. So we have different types of imaging or the radiographs, which will be periapical radiographs, panoramic radiographs, and CT scans. The distortions is as such: periapical radiographs has 14% distortion, panoramic radiographs has 23%, as this is the highest distortion among three of them, and CBCT has 1.8% distortion. So CBCT is much more reliable and accurate as compared to other radiographs. So these are the CBCT slices or images with a different view, including axial view, sagittal view, panoramic views. And application and planning is very important, and these are the aspects that we can rely on CBCT slices to plan accordingly. Virtually we can plan the implant position, the width, length, and also vital organs like mandibular, inferior alveolar nerve, sinuses. So we can plan, and we cannot involve such vital organs. So in those cases, CBCT planning is much more helpful. So let's see the implant guides or stents. So the advantages of the stents are it helps in the ideal position of the implant. It also decreases the surgical time, complications, and trauma that are involved with the surgical placements. So the characteristics of the ideal guide or stent would be it can be radiographic or surgical guide. It allows three-dimensional placement of the implant made to have radiographical contrast, which the guide should be stable during the oral manipulation. It should be easy to use and allow for a good surgical visualization, allow external irrigation, transparency, and it should be easily corrected. So implant guides could be radiographical guide and it could be surgical guide. So in the radiographic guide, we have Gatta Parcha radiographic guide, or we can use the barium sulfate radiographic guide. And in surgical guide, we have lab made or lab fabricated surgical guides and CAD/CAM based surgical guides. Let's see one by one. In radiographical guide, the picture is showing that the Gatta Parcha, that will be radio opaque, will when we are using the Gatta Parcha, that will replicate on the radiograph as a radio opaque object. That's where the implant placement should be ideally. So the second material in radiographical guides will be barium sulfate. It is pretty much similar to Gatta Parcha. It is also radio opaque. and it can be used to plan for the implant surgeries. In surgical guides, we have lab fabricated and we have CAD/CAM surgical guides. Lab fabricated would look like this. So that will be made from the lab, and it's arbitrarily made according to based on the model or cast. So this is a CAD/CAM CBCT. So as you can see it from the picture, it has a channels. It will be stabilized into the jawbone. So it will be much more accurate, and it will have access channel for the drill sequencing. So CBCT or CAD/CAM guides will be of three types: bone supported, mucosa supported, and tooth supported. Let's see one by one. So bone supported, obviously it will be seated on the alveolar jawbone. As you can see on the top picture, the flap is completely reflected, and the guide will be sitting on the alveolar bone. The lower left picture, the mucosa supported guide is sitting on the mucosa. That's why it is called as a mucosa supported. And the right side picture is showing the tooth supported CAD/CAM guide. So now let's see the osteotomy preparation. So osteotomy preparation, the steps will be: you have to design the flap, then reflect the full thickness flap, and if you need to reshape or adjust the alveolar ridge, you can do so. The next step will be initial marking drill. So initial marking is prepared with the round bar. This is used to make a divot in order to position the twist drill and stop it from jumping out. So water irrigation is the key factor during these steps. So twist drill. Twist drill, use of a 2 mm diameter twist drill is placed into the initial divot and the drill is engaged. This drill is established, the depth aligns the implant, depth markings are present on the drills. Use the longest drill possible to ensure the proper alignment. Then use the guide pin to take the periapical radiograph. So place the piece of a floss on the guide for the retrievability. Take the radiograph and decide the angulation and the depth. So then sequencing the drill. After a series of the drills, depending upon the diameter of the implant fixture, a final preparation is made, which is 0.6 mm or approximate 0.5 to 0.6 mm undersize. Then countersink. Depending upon the implant system, a countersink drill is used to widen the entrance of the recipient site and allow for the subcrustal placement of the implant collar. Then the last step will be the fixture placement. Implant is inserted into the prepared osteotomy site with a handpiece or handheld driver at the slow rate. Then depending upon either one stage or two stage surgery. If it is a two stage surgery, then place the cover screw on top of the implant. If it is a one stage surgery, then go ahead and place the healing abutment on top of the dental implant. So then comes this is the slide of a drill sequence. So there are variation depending upon which system you're using. This is just the overall guideline, starting from 1.5 drill, then pilot drill, then surgical drills, all the way till 4.7 millimeter drill, or 4.4 millimeter drills, and then last one will be optional drill, which will be used in the dense bone. And then the final step will be the placement of the fixture. Also in the drill sequences, we have shorter length drills and we have longer drills. So depending upon the mouth opening of the patient, you can choose either longer or shorter drills. Then let's see the restorative options. So implant dentistry is restorative discipline with the surgical components. So in the prosthetic options, we have screw retained crowns, we have cement retained crowns. Implant bridge, implants act as abutment. Then we have implant assisted partials. Partials implants act as a stabilizer. Then we have hybrid. Hybrid could be fixed or removable. And then we have overdentures, which will be removable appliances. Let's see one by one. So screw retain and cement retain. Both screw retain crowns and cement retain crowns they have advantages and disadvantages of their own. In cement retain crown, the advantages, it looks much more natural and more aesthetically driven. But the disadvantages of the cement retain crown, if the residual cement will be around the crown, that will cause peri-implantitis and it can also irritate the gingival tissue. Let's see the screw retain advantages are the easy access if we need to retrieve it, the easy access to the screw channel, and there is no cement required. The disadvantages of the screw retain crown will be that there can be a crown can chip off, and also it has a cosmetic issues that the metal can see through it. So this is the next option in restorative phases, the implant bridge, as you can see from the picture. Next will be implant assisted partials, and then we have hybrid. Hybrid could be fixed or removable. And then we have the final one would be overdentures. Overdentures is basically the dentures are snapping onto the dental implants. So these are the overall guidelines. So whoever will be starting to place the implants now, these guidelines, implement these guidelines, and I promise you, you will get the good results. So I hope you liked this presentation. Thank you so much.
Thank you, Dr. Vishal, for an excellent presentation. I think these are very basic but very useful guidelines for someone who's not done implant dentistry or who's done very little. And it is like a good reminder for people who have been doing implant dentistry. Well, as always, when we say you've been doing something so routine that we forget the details, and this is sort of a good revision for all of our specialty colleagues as well as general dentists who want to start getting into implant dentistry. Thank you so much for the presentation.